Okay, good evening everyone, and welcome to this teaching session, which is organised jointly by the FRCS Mentor Group and Orthopaedic Research UK. I'm Nicola Evans, and I'll be running the session this evening in combination with the rest of the mentors. We have two speakers for you this evening. We have Mr. Tom Crompton, who's a consultant paediatric orthopaedic surgeon at Brighton and Sussex. He undertook his fellowships in Westmead Children's Hospital in Sydney and at the Royal London Hospital. And he's also the convener of the OR UK Paediatric Trauma course. We're then going to move on to Mr. Kyle James, who's a consultant at the Royal Alexandra Children's Hospital in Brighton. He's a UK trained surgeon and has done 2 international fellowships in paediatric orthopedics. He's worked as a mission surgeon in Malawi and was a consultant at the Royal London Hospital. He's experienced in paediatric and adult trauma. He's a senior lecturer on the Trauma Masters Programme at Queen Mary University, and he's got 16 peer-reviewed publications. So for this evening, we're going to do the upper limb trauma talk by Mr. Crompton. We've then got some MCQ questions. We will move on to lower limb trauma by Mr. James, again with some MCQ questions. And then we will move on to questions from the group. After that, we will do some Viva practice. So we want to give priority to those people sitting the Vivas in November and February. So if you can let Ruth or Abdullah know in the chat box when you're sitting the exam and if you'd like to be considered for a Viva, and we will list them in order of priority and whoever raises their hand first. If you miss any part of this lecture, don't worry, it will be recorded and it will be available on YouTube. The Viva sessions will not be recorded. And we will Ruth from OR UK will send you out some feedback, and we'd be grateful if you could fill that in for us so we can continue to improve. So without further ado, I will hand you over to Mr. Crompton for his talk on upper limb trauma. Thank you.
Good evening, everybody. Thank you for that introduction. Hopefully you can all hear me okay. I won't introduce ourselves again. Carl and I are working here at the Royal Sussex County Hospital, the only major trauma centre with a view of the sea. Currently, it looks like a bit of a building site, unfortunately, but that is the future. So I have a lot of trainees with me, and the feedback from the exam is I get the questions that people are asked every sitting, and still common things are common, and supracondylar fractures tend to be asked to almost everyone. So most of the talk side of this evening, I'm going to go through supracondylar fractures. My aims of this are to give you a plan, because I think the paediatric part of this Viva is a place where you should be aiming to get an 8. There's a limited number of things people will ask you about, and very clear plans and guidelines that you can follow to really sort of impress the examiner. Will come up in the Vivas, and we can discuss that then. But I want to get across in the sort of 15 minutes I've got things that tend to trip people up regularly in the feedback I get from the exams. So the aims of this session are to give you a plan for theatre for when you're asked, a brief discussion about lateral versus crossed K-wires, so you can decide, and then what will always come up in the exam is the pink pulseless hand. And I'm going to give you one safe, effective way of managing that, guidelines, my experience, and a bit of an evidence review. There is a health warning with this. There's no incontrovertible evidence, and everyone has their own opinion. But what you want in the exam is a clear, effective way of answering it. So that's what this session is about. So we're not really talking about this. This may not project perfectly on your computers, but that's a sort of Garland 1 undisplaced fracture. I couldn't really care if you treat that in a in a sling or a plaster, all will do fine. You're not really going to get that in the exam. Again, not really contentious is your sort of Garland 2 supracondylar fracture. We can discuss that in the viva. Beware though, if you're going to be shown a picture in the exam of a apparently simple fracture, excuse me with my video, my kids after. Just beware if you haven't examined the wrist, or you can see the wrist on the X-ray, because as we'll see from the vivas, the question can go in a slightly different direction, but otherwise you'd manage that as with any supracondylar fracture. What I want to spend a bit of time on is your plan for this, because this is what you're going to get in the exam. It's pretty much always going to be 8 or 9 p.m. at night when this child comes into your examination or into your hospital, and pretty much if the limb is ischemic, then that's an easy answer for you. Or if the limb is completely well perfused with a good pulse, that's an easy answer as well. So we're going to spend a bit of time talking about the pink pulseless hand. So when asked this in the exam, you just want a clear guideline-based, sensible approach to doing it. So you're going to document a neurovascular assessment. You're going to talk about the setup in theatre, which I've got a slide for later on, where to put the image intensifier to make it sound like you've done this many times before. You can say whether you want an assistant or not. I'd suggest being able to do it solo in theatre. An old boss of mine used to say, you know, the reduction maneuver, slight flexion and traction for the whole of the stairway to heaven, depending on where you live. It's just for a long time, you know, letting the muscles relax to allow you to do that. And as I said, we're going to talk about K-wire configuration. You need to be aware of the BOST guidelines for supracondylar fractures. They are guidelines, but they're pretty clear about having to have a documented assessment of limb perfusion, both pre and post-op. If the limb remains ischemic, there's no timelines given, but if after your open or closed reduction, exploration of the brachial artery is required. And on that note, in the viva, you need to have an idea of how you're going to approach your open reduction. Again, it doesn't really matter. It's opinion-based, whether it's laterally, medially, or anteriorly, but you've got to have a plan. And again, we can discuss that in some of the viva cases. The BOST guidelines say nighttime operating is not necessary unless urgent indication for surgery. Doesn't really give absolutes, but again, we can discuss that in a bit. And it also says if a medial wire is used, a technique should be used to avoid injury to the ulnar nerve. If you look at the American guidelines, actually, and the American Academy of Orthopedic Surgeons, they just recommend lateral wires, and we'll go into a bit of that later. They also say 2 mm wires should be used where possible. Just beware with the very young children. If you're seeing an X-ray of a, you know, it might be unusual, but a very young child, then you probably wouldn't jump in straight to saying 2 mm wires, because it just doesn't sound like you've hung around the children's theatres too much. So we use a pro forma because we found that however much we tried to persuade registrars to document clearly about the neurovascular status, it never happened. Now we've introduced this pre and post-op, or I should say Carl James introduced this pre and post-op, that our documentation has become much better. My recommendation for both for life actually in general, but also for the exam, is to set up for supracondylar fractures like this. And certainly for the off-ended supracondylars or the flexion type injuries, if you have your C-arm parallel to the table and the patient, it allows you to swing through for a lateral without having to flex up the elbow. And for the particularly unstable injuries that you're struggling with, that can make a world of difference. And saying something like that in the exam, together with the other things you're saying, will give you a will certainly give you a head start in aiming towards your 8. So for the pink and pulseless hand, you can always find evidence to take you down either track, to be honest. These are slightly old papers, but they're still useful. So the BOSE guidelines are based on some of this, as in whether you wait less than 8 hours or more than 8 hours. This is with Garland, off-ended supracondylar fractures with a pink pulseless hand. There wasn't shown to be any adverse outcome from waiting till the next morning. So in your exam, you can go down the BOSE guidelines route and say they'll be first on the list the next morning, depending on the time of day. Also, other papers have shown some quite significant vascular injuries with if the pulse doesn't return. So I think you're always on good ground, depending on the time of night we're talking about, to just say if you're competent and confident to just go to theatre within reason, sort of almost any time of night. So don't be pushed down one route or other. AOS guidelines say in the absence of any reliable evidence, open exploration of the antecubital fossa should be performed in patients who have a pink pulseless hand after reduction and pinning. Again, they don't give any timeline on that. You might want to use a Doppler, or obviously wait for things to warm up and wait a few minutes before diving into the antecubital fossa, but it's certainly something to be aware of. So again, people have different ideas of, different surgeons will have different ideas of what is in their practice. But I'd suggest in the exam just having a definitive idea of how you're going to treat it, and you can back that up with evidence. Now, I've barely put a medial wire in years because of papers like this. So someone is injuring ulnar nerves. Obviously, we're all the best surgeons in the world, so it's never us. But I think this is enough reason to try and treat supracondylar fractures with lateral wires, and if done well, there's no clinical difference in the outcome. Only a sort of theoretical mechanical difference in the fixation. So being aware of papers like that to back yourself up when you're in the exam can be very useful. So just a slight technical point, I think it's very useful to try and visualize what you're trying to do when you're doing two lateral wires, and get two wires crossing the fracture site in either half of the humerus. Obviously, there's no concerns about crossing the capitellum or the olecranon fossa. As long as you've got that decent spread at the fracture site, you'll have a good outcome. And you can always use a third wire if you don't have the stability you desire. So the reason I set up all supracondylar fractures in the same way with the C-arm along parallel to the bed, just so the theatre staff and everyone working with me gets used to it. And I think that's a reasonable thing to do, because particularly if you're presented with something like this in the exam, a flexion type supracondylar fracture, you want to just show that you're aware of the difficulty with reduction and pinning of these sort of fractures, and just mentioning that you've set the patient up like that, so you're able to swing through for a lateral without having to mess around positioning the arm, would just fill me with confidence if I was sat opposite you on that exam table, to show me that you've been there and done it. They're obviously pretty rare, but it's just useful. And some of the very unstable extension type fractures as well, it's always very useful. So as I say, I ask all our registrars, and you should talk about this in the exam as well, to assessment of stability after you've fixed the fracture, and get a view in external and internal rotation. And if that's still slightly unstable, you can put a third wire in. I understand that's not what everyone would do. You may put a medial wire in, and there's not a right or wrong there. It's about what you're used to doing and where you were trained. But it's perfectly reasonable to put a third wire in if that's what you're confident doing. They might then move on to ask you about the complications, and it's best to talk about the sort of malunion and deformity rather than a growth arrest in supracondylar fractures that gives us that common gunstock deformity. You need to be aware that that's mostly a cosmetic issue. If you're getting on to discussing that, you're doing incredibly well. And never forget the compartment syndrome with concurrent distal radius fractures. So that is my run through of supracondylar fractures. We're going to talk much more about the other injuries that come up commonly in upper limb trauma. I just think the best place to do that, to go through so many of them, is in the vivas that we'll be doing in a little while after Carl has had a chat to you. So thanks for listening. We're going to do questions at the end of Kyle's talk, Kyle James, in just a sec. So if you've got any burning questions for the regarding supracondylar fractures, you'll have to wait just another few minutes. So thank you for listening.
Thank you very much, Mr. Crompton.
Well, you need to try and recreate Bowman's angle. Now, I just do that by physical examination, just examining the other limb to see what it is on that side. I don't sort of try getting angular measurements out in theatre, trying to recreate Bowman's angle. I would literally just examine the other good side. Hopefully they've not had a lateral or supracondylar fracture before. Otherwise, I'll just go with the normal for humans. But no, I don't measure it. Both, you need to take it into account. I don't tend to X-ray the other side either. Actually, I just do a clinical examination and recreate that on the injured side. I don't know what anyone else's thoughts are on that. I'd be interested. But.
Mr. James?
Yeah, I don't use it practically. It's really, Bowman's angle is what we use in follow-up when we think we're trying to assess if it's going to go into varus. I think normally you're just restoring the column anatomy, and it's not really useful in the grade 3 in the pre-op. Intra-op, you're using image guidance to check your reduction. And Bowman's, we tend to only measure when we're following them up in long-term follow-up.
Brilliant, thank you. If you're ready with your presentation, yep. Thank you.
Fantastic. So guys, we're going to try and go through some of the lower limb fractures and discuss some of the things you need to think about in a viva situation. And so it will help you to answer the question a bit better and try and flesh out some of the difficult controversies. So I'm going to talk about slip to Physis first, because this frequently comes up in a viva. The important thing is that we need to start talking about slip to Physis in terms of stable or unstable, Lotus classification, and the stability is the ability for the child to weight bear. Now, stable slips, there isn't much controversy when we come to management of a stable slip, but you need to understand that treatment might change depending on the severity of the slip, how great the slip angle is. So mild slips, we measure as a less than 30 degrees or 1/3 slipping. We will pin in situ. A single in situ screw fixation is the accepted method of treatment, which has the best long-term follow-up. When you get onto a moderate slip between 30 and 60 degrees, unfortunately, this leaves a bump, which can lead to impingement later and develop arthritis at a later age. But still, the management of stable, moderate slips is still a fixation in situ with a single pin. Now, whether or not we go on to manage the bump later, either through arthroscopic or open means, is still debated. And we don't know if this changes the natural history of these slips. There's still some new methods using growing screws to see if the hip can remodel with growth, but we don't know whether or not this will be the answer. So all you need to know for a moderate slip, the child will have a bump which can lead to impingement and can cause arthritis or labral pathology in early adulthood. Now, severe slips we'll discuss a bit later on. Unstable slips are the biggest area of controversy. And for that reason, the management of unstable slips is trying to be centralized in the UK. So it tends to be managed mainly in pediatric centers, because there's no consensus on when we should operate. Should it be immediate or should it be delayed after a period of traction? What's the best way of operating it on this hip? We don't know whether we should try the serendipitous close reduction, a mini open, or a formal open with a done procedure, or a surgical dislocation. What we do know is that unstable slips have a high rate of AVN, and even the rate of AVN differs throughout the series. A systematic review shows between 10 and 60%. So the AVN rate differs, and we don't know what causes AVN. Is it kinking or disruption of vessels at the time of the slip? Or is it pressure from the hemarthrosis in the hip, reducing the blood supply? So when we talk about AVN, you'll need to know about the medial, the deep branch of the medial femoral circumflex that supplies the epiphysis. So these are things that you need to talk about, maybe around anatomy. But what isn't controversial is that we tend to do some sort of, the fixation should be at least 2 screws when we try and fix these, because they're unstable slips, and 1 screw we can cause, if we just fix it with 1 screw, the slip can then continue to lose position in follow-up. So we tend to use 2 screws. There's the trend is to do some mini open at least to try and release the hemarthrosis, because we feel by releasing the hematoma or the hemarthrosis, we may reduce the chance of avascular necrosis. So for the exam, you'll need to say these are rare injuries, high risk of AVN. You're going to manage them in a pediatric center because of the controversies around it. And we will definitely use 2 screws, and we'll try and drain the hematoma. And we may do an open reduction depending on the skill level of the surgeon and their training. Now, when we talk about severe slips, these are slips over 60 degrees. These are also a challenge to treat. They're chronic, and they may have been going on for a long time. And to assess them properly, we often have to do a CT to see whether or not the physis is open, because that will dictate what type of procedure we'll do. Now, a 60-degree slip is quite a severe angle, and even extracapsular osteotomies, the limit of correction is around 60 degrees. So an extracapsular osteotomy will only correct up to 60 degrees, and then we have to think of a open bumpectomy to try and reduce the final bit of the anterior bump. We can use surgical dislocation and subcapsular realignment if the physis is open. Now, when we talk about fixation, and they might tell you about how you do it and the complications related to it. So you'll need to know whether you're going to do it on traction or freehand and using the image intensifier. You need to be able to talk around this procedure. I know I personally do it freehand because I feel that's easiest for me to get a good frog lateral in a stable slip, and then I can just keep the C-arm in the AP position. Joint penetration with a screw can lead to condylolysis. If the screw is not centered of the head, it can lead to poor stability and loss of fixation. If the screw comes too posterior, you can risk damaging the deep branch of medial femoral circumflex and increasing your risk of AVN. If it's not anterior in the entry or too low on the lateral entry point, you can increase the risk of developing a fracture. Measuring the slip angle, we tend to do to decide whether or not we should fix the other side. When we measure this, the posterior sloping angle of the contralateral hip, this helps us to predict whether or not we should do a prophylactic pinning. So if you draw a line from the anterior to posterior margins of the physis, a perpendicular line is drawn, and then a line along the axis of the femoral neck. This slip angle, if it's over 14 degrees, anatomically is more associated with a subsequent slip in that hip. And we have a numbers needed to treat of around 1.7. So that's something you can talk about as a decision-making process regarding prophylactic pinning. And remember, there's the bump that's unfortunately can lead to impingement and arthritis later on. When the principles for dealing with intracapsular Necco fractures are quite similar. Depending on how much neck we have, we might try and use 2 screws in an extraphyseal manner, whereas in a slipped epiphysis, you have to go across the physis. The aim is to fuse the physis. Now I'm going to move on to femur fractures. And as Tom was alluding, that majority of pediatric trauma comes after school, on a weekend, or in holiday time. So this is when there tends to be registrars that are running the on-call without consultant cover. In summer, people might be on leave. So you need to be able to know how you'll do the emergency management of many of these fractures. The important thing about femur fractures is that they still have quite a high association in the under 3 with non-accidental injury. And the highest risk is in an under 1-year-old, a child that isn't walking with a femur fracture. Now, and the important thing when we think about non-accidental injury, these children often present late. They don't tend to arrive by an ambulance, and the history of the injuries usually does not support the fracture that you're seeing. So they will want you to talk about the management, but remember, most of these children are coming in the evening, so don't forget to talk about pain relief, because you're likely to manage them on the next available trauma list in a planned way. So you need to talk about pain relief, whether or not you're going to use a femoral block, and whether or not you need to use some sort of traction overnight. So there's quite a few guidelines on how to manage femur fractures. And for children on the age of 6 months, we use a Pelvic harness. It's simple to put on, and the fractures heal very well in a Pelvic harness. You might need to talk around about how to put on a Pelvic harness, what the different straps do. And don't forget, you have to say you're going to investigate the child for potential non-accidental injury. Between 6 months and 5 years, we go for an early hip spica. Remember, once again, under 3, we're worried, is this a non-accidental injury? So discuss that. The decision-making on whether or not we do an early hip spica or a hip spica after a period of traction depends on the stability of the fracture. And we look at the amount of shortening that happens on the femoral fracture. If it can shorten more than 3 centimeters, then these are best managed with a short period of traction before putting on a spica. When we talk about spica, you can use a single leg spica, a 1.5 spica, or both limbs, depending really on the size of the child. And the smaller the child, the more of the contralateral leg you'll need to include. The most important thing is about your position of the leg. How much flexion you have at a hip or knee is dependent on where the fracture is, if it's in the proximal, middle, or distal third. And you also want to do a slight mold to avoid any varus malunion of the femur fracture. A varus malunion has a high risk of refracture because of the eccentric loading of the femur. Our child between the age of 5 and 11, the management is either a flexible intramedullary nail or some sort of open reduction internal fixation, usually with a MIPO bridge plating. We decide what we do depending on the fracture stability. So flexible nails tend to be used for fractures within the diaphysis of the bone. So you can see these dotted lines showing we're looking for a fracture within this kind of central area of the femur. So you can have a entry point which is far enough to give you that stability, that tension. You want to talk about the hoop stresses that you'll develop with pre-bending of the nail. So we look at the fracture location. We look at whether or not the fracture is length stable. So very comminutive fractures will shorten even with a flexible nail, and then you can have failure of your fixation as a result. So the fracture pattern determines how much length stability there is in the femoral fracture and whether or not we can use a flexible nail. So fractures that are around the metaphyseal region are length unstable, we tend to use MEPO plating rather than a flexible nail. Now, the important thing is that there's a weight cutoff for flexible nailing. We say around 50 kilos, we would prefer not to use a flexible nail because we see failure of the flexible nail. We know that we can use a stainless steel nail, which is actually a bit stronger than a titanium nail and still gives you the same hoop stresses. Now, to figure out for a stainless steel nail is equivalent to a titanium nail of 0.5 millimeters bigger diameter. So you can use two smaller stainless steel nails if the isthmus is quite small to get more stability, more strength. The use of end caps are used for length unstable femoral fracture patterns. However, the end caps also cause soft tissue irritation of the knee and can result in early removal of the metalwork because of soft tissue irritation. Now, when we go to a more adolescent, over the age of 11, we're moving on to locked intramedullary nails with trochanteric entry. And there's several different ones on the market. We use the PD nail by Orthopaedics because it has a recon screw or a straightforward interlocking screw for a mid-shaft fracture. The important thing is that we're doing a lateral entry in the trochanteric apophysis, and this avoids damage to that medial circumflex femoral artery. And this minimizes the risk of AVN. Now, when we look at the knee, some of the knee fractures that you'll be asked to talk about is really the distal femur is one of the ones that we would see commonly that might need a urgent treatment. Now, the important thing is that there's the femoral neurovascular bundle is running behind this injury, and there's a high risk of injury to the neurovascular structures with very displaced fractures. So it's important to state that you're going to do a neurovascular assessment. These are usually high energy mechanisms, and they may be associated with ligamentous injuries. So you might do an EUA or required to do an MRI after this injury to help with the management. You can also talk about anatomy of the distal femur physis because of its undulating pattern and that this fact is more concave posteriorly. There's a higher risk of growth disturbance. And this runs to around 50% of these injuries have growth disturbance. So how you manage it, it can be either with cross wires or if there's a large Thurston-Holland fragment, as in this fracture, we can use screws to fix the Thurston-Holland fragment. Next adolescent type injury we tend to see is a avulsion of the anterior tibial tubercle. The tibial tubercle, sorry. This is an ACL avulsion, and it's recommended that an MRI is probably the best way of assessing this injury because you're able to assess the soft tissue structures that can have additional injuries. You might have a meniscal tear at a time. The treatment is a extraphyseal screw or a suture repair. Both are equally equal in terms of fixation strength, and it really depends on the size of fragment whether or not you can use a screw or not. Proximal tibial fractures, the ones we tend to use are tibial tubercle avulsion fractures, and these can vary from very minor injuries to much more severe drastic injuries. And the important thing is this is a high energy injury, can be associated with a intra-articular injury to the meniscus, anterior of the meniscus. As this fragment is pulled off with the patellar tendon, it tears quite a long soft tissue sleeve of the tibant muscle and can cause quite a lot of bleeding into the anterior compartment and result in compartment syndrome. So it's quite important to be aware of compartment syndrome in this injury, and we try and anatomically reduce this because it's intra-articular, and we also want to prevent a growth disturbance to proximal tibial epiphysis. So there's a screw here in the epiphysis and one in the metaphysis. You still have to follow these up because you can get late deformity of the proximal tibia with a recurvatum developing. The next most common injury is a patellar sleeve avulsion. Once again, it's an injury to the quadriceps mechanism. The child will have an inability to do a straight leg raise. It can be quite subtle with a high riding patella, and you might not see a little sleeve fracture. But remember, this is an intra-articular injury where the cartilage is separated and a small piece of the bone is attached to this. So you once again might need to have an MRI to aid the diagnosis in a young child, but the management is a open reduction internal fixation, usually with a transosseous suture repair. Now, if we move on to tibial fractures, obviously tibial fractures are still very common in children, and they remodel very well. But with an isolated tibial fracture, whilst managing in plaster, you have to remember isolated tibial fractures can have this phenomenon of varus drift due to the pull of muscles. So in the lower third, it starts to drift into varus. So often the plaster will need wedging around the 2 to 3 week mark. When both tib and fib are broken, it tends to drift into valgus. So once again, at a 10 to 14 days time, you might have to wedge the plaster to improve your alignment. A couple of eponymous named fractures. In a very young child, you might have a toddler's fracture. This is a common reason for an undiagnosed injury in a limping child. And often you may need to repeat the x-ray in 10 to 14 days to see if there's any callus. Whether or not it needs treatment is still debated. Many can just be given no immobilization. Some children need a small walking boot or temporary plaster for 2 to 4 weeks. Crozens fractures, fractures of the proximal tibia, which have this phenomenon of valgus overgrowth. So as it heals, the leg then develops a valgus deformity later on. When we follow up Crozens fractures, we know that this valgus tends to correct in the majority of children within 2 years. If it doesn't, we can simply manage it with a guided growth procedure where we put something called an 8th plate or a temporary epiphysiodesis plate on the medial side to allow the lateral side to keep going growing to recorrect the valgus. Now, when we move down to ankle fractures, you'll see from this this graph that depending on the age of the child, we'll see different Salter-Harris fractures of the ankle. So the younger child, we tend to see this type 1 and type 2 fractures, sometimes the type 4. As they become more adolescent, you then see the triplane fractures. Now, the reason behind this is how the distal tibial epiphysis fuses and the Physis fuses. So it starts just over the medial malleolus. It starts in the central area there, and then the medial malleolus fuses around 13. Then it progresses towards the lateral side, and the last area to fuse is the Tilleau fracture area. So Tilleau fracture tends to be in a slightly older adolescence because it's the last area to fuse in the distal tibial physis. But depending on the age of the child or the stage of physoclosure, we get different triplane fracture patterns. So the triplane fracture pattern is just because part of the physis is fused, it goes through the weakest part, which is the unfused physis. So the younger you are, the more chance of getting more fragments. The older you are, it tends to be just the Tilleau. Now, you might be asked about the Laug-Hansen classification for adult ankle fractures, but also it's the same for children's fractures, and Diaz described it. And remember, it's the first thing, supination is position of the foot, and the next term is which direction the foot moved or the limb moved. So supination inversion. So the foot was supinated and then there was an inversion force. And you tend to get these Salter-Harris 4 fractures. And these can actually have quite a high rate of growth disturbance. The most common type we see is a supination plantarflexion, where you have this physical fracture, often with a posterior Thurston Holland and a little bit of displacement. It's very low risk of any physical closure here. When you go to the supination external rotation, you'll see this fracture pattern where it starts off quite low on the lateral distal tibia and exits higher up. So looking at the angle of this fracture pattern will help you to know if it's a supination external rotation or a pronation external rotation, which tends to have the Thurston Holland on the lateral side, where the Thurston Holland's on the medial side. And I've shown you the rates of physical disturbances with these injuries. But the most common type is we see this supination plantarflexion injury, and you'll see there's a gapping at the front of the anterior aspect of the tibia, and this is due to the infolding of the periosteum. So if you're unable to reduce this closed, you don't force it, you often need to do a small mini open reduction and fish out a periosteum and then reduce it. You may need to put a single wire to hold it, or just a plaster to keep it stable. If there's a large Thurston Holland fragment, you might use a screw to fix it. So foot injuries, majority of foot injuries heal very well in children. And most heal just with some immobilization and walking boot. I guess the Jones fracture, remember, is potentially might take a bit longer to heal in a child. But so we may just immobilize the foot between 4 to 6 weeks. But it's not the same as an adult fracture. There's much less risk of non-union. And if it does become a non-union, it's quite easily managed with screw fixation. The only other foot fracture to remember is the Seymour fracture, which is an avulsion of the nail bed out of the nail fold, associated with a Salter-Harris fracture of the distal phalanx. So it's important to know that this is an open fracture and we need to do a nail bed repair and treat the child with some antibiotics to prevent any infection. Okay, thank you very much, guys.
Thank you so much. So that was 2 very good lectures, and I'd suggest that the participants watch those lectures again, because these questions do come up in your vivas, and you've just been presented with a perfect way to answer them. So thank you very much for that. We do have some questions. So we've got one from Melindo Makandawa. Melinda, I think Mr. James answered this, but we'll just clarify it again. He said if a kid comes in the evening with a displaced supracondylar fracture with no vascular compromise but an anterior interosseous nerve palsy, would your advice be to operate overnight? Can the anterior interosseous nerve palsy be due to neural ischemia or compartment syndrome?
So yeah, so just say isolated nerve injury tends to be a neuropraxia at the time of the injury. And this year, I can't remember, it was JBJS or JPO, there's a meta-analysis of nerve injuries and supracondylar fractures showing all the long-term natural history is that most of them resolve within 9 months, not the 4 to 6 weeks, but 9 months for them to fully resolve. I would just say that the caveat for nerve injuries is if there's nerve injuries with vascular compromise, this is usually indicative of a much more serious mechanism. And these are where if you're seeing a pulseless limb with a nerve injury, often this means there's much higher energy, and this is where you'll be talking to either vascular surgeons or your peripheral nerve injury unit. And the peripheral nerve injury unit won't need nerve conduction studies. If you have that mechanism and you're not doing an open reduction, you get the pulse back, you can refer them even before the 4-week stage and they will see the child, because some of these may be a damage to the nerve. Tom?
Just to add into that, for the exam, you know what the question's going to be. Just prepare your answer before the exam. The exam is not the time to be thinking about the exact rights and wrong. You can, the nerve injury, the mild AIN palsy, it doesn't come into it in terms of the timing of your operation.
Mm.
If the hand is white, you're going to operate at any time of night.
Yeah.
If the hand is pink, you're going to leave that till tomorrow if you follow BOST guidelines. There is the only grey area in between you don't really need to get into in the exam. That's for your practice, when you're consultants, and I'd go to theatre almost at any time of night if there's a nerve injury, even if it's a pink hand and it's pulseless and a nerve injury, I'd almost certainly go to theatre. But you're backed up by BOST guidelines to say leave till the first case on the list the next day. And I would just choose one of those options, and no one's going to say you're wrong when it comes to the exam.
Thank you. We've got a question from Daniel Bouchette, and he's put, are posterior intrafocal wires ever helpful?
I think majority we can reduce closed. I know there's a temptation for some people to use that wire at the back to flick it back on, but remember the anterior structures are there, and you often need to make sure it's a blunt end. It's quite a risky technique, and it often causes quite a big scar at the back of the arm as you pull it down. I think if you're having difficulty to reduce the fracture, you might be thinking there's something within the fracture preventing this. And it's often the muscle is buttonholed through the muscle at the front, and that's causing a block to reduction. And you will be pulling quite a lot with the wire, bending the wire to try and aid the reduction.
And again, this will come up in the vivas later on, but as also part of your practice, the exam is not the time to decide which way you're going to openly reduce. Just decide before in your practice and for the exam, and have a reason for it. So, some people will always go either lateral or medially. I tend to go anteriorly for the reason that Carl just said. You can always it's not a huge approach. You can just push the bit of bone back through the brachialis, and that's your sort of operation done, and it makes it much easier for any vascular surgeon who's following you in if the hand remains pulseless. But there is no right or wrong, so it's difficult to tell you what to say, but you should come up with that plan before, because when I'm practicing vivas with a lot of registrars just before their exams, they tend to be thinking about that on the hoof, and that's not the time to be doing it.
Thank you. I've got a question from Atif, and I think Adele is asking the same question. Is there a difference in how the manipulation is performed compared with a flexion type fracture?
Yes. So again, in your viva, I'd really like you to describe to me what you're going to do. And I tend to take the registrars, as most people, through a sort of staged approach. So before you've done each bit, this is for the extension type fractures. You're going to put traction with a bit of flexion until it looks okay on the AP, and then you're going to do your reduction maneuver. Obviously, if you're flexing right up, that's just going to completely displace your flexion type injury. So the reduction maneuver is different. They tend not to need so much traction because they're not displaced in the same way as the extension injuries. But going back to my talk, how I set them up, and it's not the only way of doing it, but having the C-arm parallel with your bed, and then you can just move with the C-arm in a sort of taking a picture laterally. You can just flex and extend the forearm until you get it in a perfect position for your first wire. It was a colleague of Carl James's at the London who taught me that, Matt Barry, and it's always served me well. So it is a different technique.
Yeah, I agree. Yeah, there's not much manipulation. Make sure your C-arm can rotate interlateral, because you can't really do any of the column views. It's quite unstable, and it rotates as soon as you try and do a column view. So try and swing it through to lateral and an AP, and it's often just a little bit of posterior force and flexion extension, changing flexion extension to see the reduction.
Thank you. Okay, I've got a question from Sinan Adnan. He said, is the Jones view helpful in confirming reduction and alignment?
I'm going to say I don't like the eponymous views or names. It's not useful at all. I think just column views and stress views are all I would use in assessing. If you're talking about the final picture, yeah, in assessing the view.
Okay, thank you. Emma has asked, post-op supracondylar fractures, are there any restrictions to what exercises you would advise them to avoid, dependent on the fracture severity?
Yeah, obviously that's very different depending on the severity. So, you know, they're going to be in plaster for 3 to 4 weeks, and then until, if it's a, you know, for at least a month after that, they're going to be avoiding. My usual strap line is any activity that increases the risk of them falling, and I try not to get into a bat and ball game with parents on that. It's up to them to decide how likely their kid is going to fall doing what, because some people can ride a bike and some can't. So I'm not entirely sure of the question you ask. I mean, just, you know, normal range of movement exercises, perhaps supervised by a physio if it's a very severe fracture and they're very stiff. But most kids, it's normal play and activity is all they need to get back to normal.
I think just warning the parents that it takes longer. It's not 6 weeks, it'll be better. Average time is 6 months to 9 months to return range of motion. And you might lose some of the full extensions, sometimes lost. And that's normal for these things. Yeah, slightly.
Thank you. Okay, so we've got a question from Mohammed Hassan. He said a child with a isolated posterior dislocation of the elbow, would you reduce it overnight? Would you be concerned about them developing chondrolysis if it was left overnight?
So the timing is difficult there. So obviously, if we're not talking about a neurovascularly compromised arm, which it often isn't actually, then if you've got an obvious, which will probably come up in the Viva as well, you're preempting a bit, if you've got an obvious incarcerated piece of bone, often the medial epicondyle, then, you know, if we're talking about trying to reduce it in A&E, then I'd probably recommend not doing that. If it truly is a simple dislocation and you're in a safe place, a safe, you know, where they've got, you know, children's A&E with anaesthetic backup and, you know, they can give sedation or give whatever you need to give, then you should reduce it as soon as possible. Equally, if the child is comfortable and it's 3 in the morning and you think there's a incarcerated bit of bone, then obviously that's not the right thing to do. So I'm going to duck. I don't think I can give you an absolute clear answer on that because every situation will be slightly different. Just reduce it as soon as you can safely, but it wouldn't be unreasonable with a comfortable child, neurovascularly intact, to leave to the first list on the morning. Carl, I don't know whether you want to add.
Absolutely, I agree. Majority of these in pediatric A&Es where you have intranasal fentanyl and Entonox, we can do close reductions in A&E before needing to take the child to theatre.
Yeah.
Probably only
is one thing to add to that.
There is a caveat in this. In the exam, guys, you are going to you're supposed to prove yourself as a level year 1 DGH consultant. Do not do something unsafe.
Exactly.
That's the main thing. So if you can't have a safe way of reducing this overnight, take it to theatre. If it's in a safe way, and they'll usually give you a reason why it's not safe. There's a vascular going to theatre with a AAA or something like that. Then refer or wait. Seek advice from pediatric colleague or wait until the morning. Always the patient's safety comes first.
Absolutely, yes.
Okay, thank you. We're now moving on to some lower limb questions. There's 5 of them.
Just one more question to finish up there were 2 questions actually, just to finish up the subchondral. The pink pulseless hand, in terms of clarification in the exam, after reducing McK wiring and the hand is still pink and pulseless, it hasn't changed, what would you do in that scenario in the exam?
You asking me or one of the? Yeah. So for everyone answering that, And I think it's reasonable to say you'd try and get some, you'd obviously have spoken to the vascular surgeons beforehand. So they would usually be sat in the coffee room in real life, and that's what you should say in the exam. So you'd ask them to come in and help you out assessing it. They may use a Doppler, and if they can get a very good sort of triphasic signal, and it's just you cannot feel it with your, you know, sweaty gloved hands, then that's fine. If you cannot find a pulse on Doppler or with vascular assessment, and it's been a few minutes at least after you've done your reduction, then you're duty bound, I think, to do an approach and a repair together with the vascular surgeons. Obviously, you would say you're doing that.
With the caveat that you've done a proper assessment with the hand in extension as opposed to in a flex position.
Yeah.
Sorry, I'm saying this for the candidates, not.
Yeah, no, that's perfect.
And also wait a few more minutes to see if the pulse comes back, because spasm is the most common cause. Yeah. So this is the information. These are the buzzwords they're looking for on the Viva table, guys. Okay. Sorry, and I know you've answered this. You think it's safe for lateral wires, but the question is safer to use lateral wires. But the question was about stability of crossed wires versus lateral wires. If they ask you that in the exam.
Yeah. So there's no doubt mechanically in a sort of lab, when you've got a sore bone, people have done studies on it, and there is more mechanical stability from doing crossed wires. There has not been shown in large studies now that there's any clinical difference with lateral versus crossed wires. So I think that's what backs you up in the exam. But I'm not saying, sometimes I do these talks a lot, and sometimes people think I'm entirely against medial wires. That's not the case. I think it's just where you train and what you're used to doing. As long as you're thinking about, why you're doing it.
The key is to assess your stability at the end of your fixation, whatever you've done. And if you need a medial wire, safer to use a mini open to make sure you're on the bone and not in a nerve. Yeah.
Okay, we'll move on to the lower limb part questions. Sorry, Nikki, do you want to continue?
Sure. So we've got Emma again. So she said, post-op neck of Fema fractures. What are your thoughts on weight-bearing status and straight leg raising?
Okay, so number one, let's talk about a slipped epiphysis then first, and then we'll talk about neck femur. The slipped epiphysis, unstable ones, we'll keep them non-weight bearing. We look at the physis widening on the x-ray. The physis is quite wide initially. Within about 6 weeks, we see the physis narrows down. That means the physis is starting to fuse, and you can start weight bearing. So on an unstable slip, you may do a short period of non-weight bearing until you see some stability with the physis widening reducing. So that's usually between 4 and 6 weeks, and then you can start some weight bearing. Now for neck and femur fracture, if you're just using 2 screws, you'll know on table your level of stability. Sometimes in younger children, you have them in a spica as well. So I would tend to keep them non-weight bearing in an older child and within a wheelchair. Yeah, wheelchair non-weight bearing until then they can use range of motion and transfer on the other side. If they're very good, they can use crutch weight bearing on the unaffected limb.
Okay, thank you. We've got Sinan again. What would be your landmarks for your entry point for the screw fixation in slipped epiphysis?
So Sinan, yeah, you need to be able to talk through how you do this on table. So we use image intensifier, and often you put a guide wire in the AP view to put the guide wire into the center of the femoral head, the epiphysis, and you draw a line to mark the AP plane. It's not so much where you go on the lateral. The lateral is slightly anterior, and you want to get your entry point just in the intertrochanteric ridge. So that's how you will plan it. I guess you need to see it to be able to explain it. On my talk, there was a little link to a YouTube video that we did for our regional teaching that describes more in detail about slipped femoral epiphysis. So if you later you'll get a PDF of this, and you can go to that YouTube and you'll see how to do it, and that'll help you to talk it through. I think you can just draw it on a piece of paper in the exam. That might be the easiest way.
Okay, thank you. Got a question from David Badansky. He said, could you give him the reference for prophylactic pinning, number needed to treat 1.7?
So yeah, it's on the talk. I haven't put it on this one for brevity, so click on that link. It's got all the references on the SCIFI talk. There's been several papers. The latest one was from New Zealand. I can't remember the author, but that was in 2017, I believe. But it's on the SCIFI talk on the YouTube link.
Okay, great, thank you. Beravan Ibrahim has asked, what's the difference between Tilo fractures? What direction do you place your percutaneous screw, medial to lateral or lateral to medial?
So you want to try and reduce the fragment. So you'll do an anterolateral approach. So it's lateral to medial.
Thank you. And last question, I believe. What size of elastic nail would you use in a femoral shaft fracture? Okay, so
that's a good question. So we tend to look at the diameter of the isthmus, and it's 1/3 of the diameter times 0.4, and you minus 1. But 1/3 of the diameter because you're using 2 nails in the femur. But remember, the femoral diameter varies quite a lot with age, and on average, it's between 2.5 and 3. But you have to be sure, because some femoral canal isthmus are very narrow, and you can't even get a 2.5 in. And that's where you might go to a 2 millimeter stainless steel nail to increase your strength of your fixation.
That's great. Thank you very much. So I think that concludes our questions. So we will move on to the MCQs.
I'll take this moment to remind everybody that concise orthopedic revision notes is now available. The textbook written by the FRCS mentors, you can actually see it in my background. We do recommend it as a textbook, not because we wrote it, but because it's based on the experience of pretty much all the mentors, most recent who passed the exams and the ones who passed a couple of years ago. It's available in all online good bookstores, obviously.
I can see the majority of the answers now. So the vast majority, 2/3 of you got the correct answer, noting that a sort of tardy ulnar nerve palsy following cubitus valgus deformity for this fracture would be the most common. Cubitus varus is much more commonly associated as the sort of gunstock deformity seen after supracondylar fracture malunion. Someone said heterotopic ossification. That is certainly possible, but not very common, and neither the last two. So ulnar nerve palsy is correct. And then you all, quite rightly, I wasn't entirely sure the level of everyone doing these webinars. So 90% of you know your anatomy, which is fantastic, fantastic news. The thumb and index IP flexors, because obviously the AIN is the most commonly injured nerve. So well done all.
And I'll take this opportunity to thank OR UK and our excellent presenters, Thomas Crompton and Kyle James, for brilliant talks. The OR UK is a research charity which is Orthopaedic Research UK. They provide a lot of charity work in terms of research for orthopedic conditions, but also in terms of education. They are our partners in this webinar session today.
So it was a bit of a 50-50 result here on the first question. I'm just trying to demonstrate that this is actually a length stable fracture. So it's it's 2 centimeters shortening. So it has to be over 3 centimeters for us to warrant traction first. So we can go for an immediate spica and to treat a spiral fracture with 2 centimeters of shortening. Remember, overgrowth is very common in femoral fractures, so 2 centimeters is not a concern. The second fracture, trying to fish out a bit more about your anatomy. So the distal femoral physis is the one which has the most growth. It has a very undulating anatomical pattern, so it's at the highest risk of having a growth arrest. Remember, it accounts for 70% of growth of the femur. It grows about 1 centimeter a year in adolescence, and about nearly 60% of the length of the leg is from the distal femoral physis. So it's very important to follow up all Salter-Harris 2 fractures of the distal femur.
Okay, so I think we've finished the poll, so we're going to stop the recording and move on to the Viva sessions.